Hi guys, good evening and welcome again to these deliberations of Obs and Gynae MCQs, and I hope all of you are healthy wherever you are, and things are getting a little better, but then yet again they're getting bad. So these things are not going to change very soon. We're going to live like this for the next 3-4 years more, and all you interns who are working so far, working as of now, I hope all of you are in great health, and I hope all the rigmarole of and the hard internship you had of working long nights, duties, coming to work, writing discharges, getting reports, investigations. We appreciate all the work you did, and I also appreciate that you are reading for your PG entrance exam. Please believe me that all you interns who are working very hard, you have the best chance this time to crack your PG. Having said that, those people who are writing it for the second attempt, you are also going to do it very well this time because you got those extra 2 months to prepare, and I hope you've utilized this time very well. And today I've brought you some MCQs which are the common topics which come in the exams, but sometimes the common topics are the ones in which you spoil your answers. So I've got a few new MCQs, the ones few I've got from the previous exams, and I hope we can make good use of the time which we're going to spend here. So best wishes, and I'll be taking your queries as we go about these question answers, and I hope you all do well with me. And best wishes for exams, and let's start right away. So welcome to this marathon 2.0 Obs and Gynae. So we'll start with the first question. In a normal menstruating woman, ovulation is expected after how many hours of the peak of the upstroke in this diagram here? So I'm sure you can make out that we have already mentioned that we are talking about the luteinizing hormone, and when we talk about the luteinizing hormone, from the onset of the LH surge and from the peak of the LH surge, we should know the time of ovulation. I know there is some talk about the embryology book saying something else from what I teach you. So people, you should not get too upset, because this is what what I'm telling you is the information based on which I do my IVF. So if I'm not going to tell you correct, that I'm also going to spoil the eggs which are coming out from my patients. So this is with a lot of confidence that I'm telling you this answer, that when the LH surge happens, from the onset of the LH surge, here this onset, it takes around 36 hours, we can say 34 to 36 hours, but exactly if they make you answer one of these choices, you must say 36. And from the peak of the LH surge, we say it is 10 to 12 hours. So this is where we have to be very careful. So from the onset it is 36 hours, and from the peak it is 12 hours. And remember this luteinizing hormone, let me just mark this so that we don't miss out on the answer. From peak it is 10 to 12 hours. Now this luteinizing hormone, we should remember, is a proteolytic kind of an action it has. The LH mediated proteoglycans, they act on this big follicle which is ready, and this follicle, when it is ready, this follicle has a lot of intrafollicular pressure. So when the LH acts on this, the LH mediated proteoglycans, they break the protein bonds in these in this follicular wall, and this follicular wall crenates a little, and this crenation, the breaking of the follicular wall, will propel the intrafollicular pressure to push out the oocyte, and it's like a mini blast where the follicle ruptures and the oocyte comes out, and it's picked up by the fallopian tube, the fimbria. And the longest strand of the fimbria is known as the fimbria ovarica. All right, so the answer is B for Bombay. Let's move on. Question number 2. While using natural contraception methods for the purpose of contraception, a woman has increased vaginal discharge, which on examination is clear, slippery and stretchable between fingers. She should avoid intercourse for the next 3 days, can safely have intercourse, get herself checked for a vaginal infection, can safely have intercourse from the next day. Now, choice D is, I think, unnecessary choice, not much of information in that. But yes, we have to get an answer from these 3 choices. Now, the woman is basically trying for a contraception. She does not want to have a child. So while using natural contraception, she is thinking of a contraception. And the cervical mucus which she sees is thin and slippery, and there is some wetness in the vagina. So all of us know that on the 14th day of the menstrual cycle, estrogen is very high. So when the estrogen is very high, it makes a lot of cervical mucus, and the cervical mucus is thin and watery, and it is stretchable a lot. So when we put our fingers in the vagina and take out the cervical mucus, this cervical mucus can be stretched a long way and before it snaps. So this cervical mucus also is important for making the sperms travel up the cervix and reach the site of fertilization. So that cervical mucus is thin and watery, so it helps the sperm transport. So if she's having thin and stretchable cervical mucus, that's the time when she has the maximum chance of fertility. Look, spin bucket, as what I was telling you, the stretchability of the cervical mucus, spin bucket and ferning. When this cervical mucus is plated on a slide and allowed to dry, it is going to show some ferning. So spin bucket and ferning, I'm writing spin bucket SB and ferning. These two events are because of high estrogens, okay, and this helps in sperm transport. So when there is thin and watery cervical mucus, chance of pregnancy is high. Now when ovulation happens, progesterone increases, and progesterone makes this cervical mucus thick, and the sperm transport doesn't happen. So please, when we ask you tests of ovulation, don't say thin and watery cervical mucus is ovulation. No, thin and watery cervical mucus is actually just before ovulation. Thin and watery cervical mucus is because of high estrogen, and high estrogen can be seen in PCOS also. So PCOS women may have some thin cervical mucus without ever ovulating. So don't get confused, all right? Thin and watery cervical mucus is because of estrogen, and when she ovulates, there is loss of spin bucket and loss of ferning. So please remember, when we say tests of ovulation, loss of spin bucket and loss of ferning is ovulation. Okay? So, if she's planning contraception, she doesn't want to have a child, then she should avoid intercourse for the next 3 days. So answer is A. So this is what is known as the Billings method. Billings method, this is the chart on which, when she's feeling the cervical mucus consistency herself, she doesn't have to examine herself. Any woman who is aware of her body's physiology, she can feel that there is some wetness in the vagina or there is some dryness in the vagina. So based on that, she makes a chart like it is given here, and when she's feeling more moist or there is more wetness in the vagina, those are the days when she marks on this calendar, and then she avoids intercourse. So this is a natural method of contraception. This is known as the Billings method. And the cervical mucus method for Billings method, the vagina and vulva feel moist or wet, like I said. This persists for about 3 days. These are called the wet days. And remember, the last day of the wetness, that is what I told you, highest estrogen amount. So highest amount of wetness, that is known as the peak day. So that is just before the ovulation. Okay, it's the last day of the wet mucus called the peak day. So that is the peak day of fertility. Right. So I'll be seeing your doubts. Maybe I should see them now. Midway, if there is something. Maybe I'm not able to see the chat. So somehow I'm not able to see the chat. So what I'll do is that I'll continue with the discussion which we're having, and then I'll see what's wrong with the phone. Maybe just 1 minute. Yeah, it's coming now. Live chat. What is Fez? Fez asked me a question. What is the dangerous period according to the natural method? Now, don't call it dangerous. You call it the fertile. Okay. So if they are not using the fertile period method, I mean, they are not using the cervical mucus method, they can also bank on the days where fertility is maximum. So we know that on the 14th day, if she's ovulating, so 2 days the oocyte can live, up to 2 days, 24 to 48 hours. So 14, 15, 16 are days when she can conceive. And the sperms can live up to 3 days in the body of the woman, that is in the uterus and the fallopian tube. So sperms will be waiting in the ampulla for 3 days after intercourse happens. So on the 11th day, if they have intercourse and there's no egg yet, but the sperms have gone inside, so from the 11th day onwards, the sperm will live for 3 days. So till 14th day, the sperm will be living, and that day ovulation can happen and she can conceive. So from the 11th to the 12th, 13th, 14th, 15th, 16th, these days, 11 to the 16th, some books say 11 to the 17th. These are the days which are fertile, or like you said, dangerous days. All right. Right. Hi everybody, and once again welcome. And I think I'll get to the questions once we finish off quite a lot of MCQs, We'll get back to answering all the questions. Now, you are asked to explain the use of barrier contraceptives for women to a group of village women. After coitus, when should the woman remove her diaphragm? So these natural methods of contraception, they require a lot of coaching for the people. I mean, it's a little difficult for me to explain all of those details right now when we're having a discussion here. But remember, barrier contraceptives, whenever somebody asks you, please think of them as the last option. Yeah, I have been, I'm full of controversies. I agree to that. But more or less, I get them to be proven correct after some time. So please remember, barriers are not ideal anywhere but in conditions like STDs and HIV, PID, all these conditions, people are advised to use barriers. Apart from that, think of the methods which are more useful and are more convenient. So barriers is an easy answer which you people give for all the conditions which, I ask you heart disease, you'll say barriers. I say vesicular mole, you'll say barriers. Diabetes, you'll say barriers. So then why are we teaching a contraception if you're going to say barriers for every possible situation which we are discussing? So please remember, barriers is the last option. Always think in terms of the best option which can be easily used and can be used for a longer time without much inconvenience. Like I always ask you this example of a newlywed couple. So then barriers are not the answer there. All of you know that very well. The answer is combined oral contraceptive pills. Why? Because once he takes it, then the success rate is very high. The failure rate is 0.5 to 0.6, and compared to a barrier which is 14 to 20%, there's a lot of failure in those. So that's why I say that newly married couple, combined pills, couple staying in a separate city, having intercourse very occasionally, again we don't say barriers because barriers can fail and barriers interfere with the so-called sexual pleasures also, right? So we always say that if they're staying in a separate city and they're going to have a, let's say, a go at each other for not more frequent than once in 3 months or 4 months, and that too with barriers, I don't think that's very appropriate. So they have intercourse without barriers, but the woman uses a IUCD. And that IUCD is like that fill it and forget it kind of a method, because once they put the IUCD, then she's protected for good 5 years. That is with the multi-load. And if she uses the Paragard, she's protected for almost 10 years. So that's why IUCD is a very convenient method for couples staying in separate cities. Okay, so don't think of barriers as the first. Now, we're talking about women in the village and who don't want to think of long-term methods. They don't want much complication, something easy. And that's why we say, okay, fine, if they can use diaphragm as a barrier kind of a contraception, then the barriers like diaphragm, they should be smartly used. Now, they cannot be put inside the vagina and be kept inside. Please, she can have toxic shock syndrome. So the diaphragm is inserted before intercourse, around good 2-3 hours before that, and it should not be kept very long. It should be kept for 6 hours at least. You must remember, at least 2-3 hours. Ideally we say if 6 hours before is fine, at least just before the intercourse if you can tell the patient to insert this. So before intercourse is best, and after intercourse keep the diaphragm inside for at least 6 hours and then remove it, because it takes around 5 to 6 hours for the sperms to totally get neutralized in the acidic pH of the vagina. So make sure it is there for at least 6 hours, and after that it is removed. So when should the woman remove? That is after 6 to 8 hours. Okay, should not be removed before 6 to 8 hours, should not be kept for more than 24 hours, because if it is kept for more than 24 hours, then it can cause a toxic shock syndrome. All right, you know about staph and strep both being implicated in that. So this is one of those diaphragms which is used. We also call it the Dutch cap. I'm sure your PSM faculties have been teaching you excellently about this. I'm telling you just the principles and we'll move on. So I'll come to the questions. We'll just do a few basic MCQs, then we'll come back to the questions. A woman using combined oral contraceptive pills for 8 years is concerned about long-term side effects of the pill. Which of the following benign tumor can be caused by prolonged use of the oral contraceptive pills? Guys, I would like to remind you here quickly that when a woman is on OCP, we are monitoring, I'll revise, we are managing the cycle by the pill which we are giving. All of you know that when the woman is taking tablets of estrogen and progesterone from outside, it is suppressing the LH and the FSH. You know that very well. So if a woman is eating a tablet of estrogen, it stops the, remember the basics, I always told you, FSH is for the estrogens, production of estrogens, because FSH stimulates the follicle to make estrogens, and LH ruptures the follicle to make a corpus luteum and make progesterons. So I have told you these punchlines, and please remember these punchlines, very important. So FSH for the estrogen, LH for the progesterone. Those who are seeing me for the first time, please write them somewhere so that you can correlate with what I'm saying. So the FSH, when it is acting on the ovary, it makes the follicle grow, and the follicle makes estrogen, and the LH ruptures this follicle, and that follicle now makes progesterone. So the purpose of FSH is to make estrogen, purpose of LH is to make progesterones. Now in a combined pill, I am giving the patient estrogen plus progesterone tablets. So this estrogen will give a feedback to the FSH, and the progesterone will give a feedback to the LH, and the pituitary will stop releasing any LH or FSH. So when there is no LH and FSH, body does not make much estrogen and progesterones. So what is the source of estrogen and progesterone in this woman? It's my tablet, it's my pill. So she's getting menstruation because of the pill which I'm giving. So her menstruation is totally under my control. I give the pill, she gets the periods. So if you understand that, then you will understand many things about combined pills, that when I give the pills, her periods become, how do they become regular? Because I give it only for 21 days. I give this combination for 21 days and then I stop it. She gets a withdrawal. So 21 days, stop periods. 21 days, stop periods. 21 days, stop periods. So she gets a regular cycle because of my tablet. She's not getting a regular cycle because I've corrected her disorder, whatever she's having irregular cycles because of. She's getting a regular cycle because of my tablet. So I'm in charge of her periods now. She's getting periods because of my pills. So when I give the pills, she gets periods in 20, when I stop in 21 days, she gets periods by 27, 28 days, the cycles become regular. Now I'm very smart. I don't give her very high dose of estrogens. What do? I give very low dose of estrogens. So this is what has happened from the 1950s. People have worked endlessly on contraceptive pills, and they are giving low dose to suppress the lowest dose, which is going to suppress the FSH. So low dose pills like low dose estrogens which we give are 30 microgram tablets or 20 microgram tablets or even 10 microgram tablets, okay, even 10 microgram pills are there in the market. So the least dose which can suppress the FSH. I'm repeatedly saying least dose. So what does the patient have? She has a very less amount of estrogen in the body. Please remember this basic. When I give combined pills, the estrogen progesterone from the body stops production. See, because I've already told you this funda, that FSH for estrogen, LH for progesterone, my pill has stopped the pituitary from working altogether. This part of the pituitary is not working. So the estrogen progesterone production in this woman is not happening. So estrogen progesterone in this woman is because of my pill. My pill I'm giving for 21 days, regular cycles. My pill I'm giving low dose. If I'm giving low dose, in the body of the woman, the amount of estrogen is now low. It's low estrogen in the body now. Please do not get confused. A lot of you get a misconception that when anybody is giving combined oral contraceptive pills, you're giving pills for so many days, so naturally the estrogens will be high. Please, that's wrong. When I'm giving combined oral contraceptive pills, the amount of estrogen and progesterone in the woman's body is low. It's less. So now you understand this, that when there is less estrogen, obviously everything will be less. There will be less proliferation, less menstruation, less bleeding and less anemia. And when there is less estrogen, there will be less hyperplasia, less endometrial cancer, and there will be less estrogenic conditions like benign breast diseases, less fibroids, less endometriosis. All estrogenic conditions become reduced. There are a lot of benefits of combined pills. So I am taking this opportunity to revise this for the people who have known this, and for the people who are seeing this for the first time. Please understand, when I give combined pills, the amount of estrogen in the body is low. But if I give combined pills for a long time, yes, since the estrogens are metabolized in the liver can take a hit, and the liver may make some hepatic adenomas. The gallbladder may make some stones, the smooth type of stones. So yes, gallbladder stones can form and hepatic adenomas can form. So answer for our question here is hepatic adenomas. And fibroids are actually lesser, fibroadenomas are actually lesser. Thyroid adenoma, there is no correlation. I have not seen it increasing and I have not read about it. This is a abstract choice given to you that also doesn't increase. So yes, this is the hepatic adenoma here on a CT which is shown, and you can see the hepatic adenoma here. So adenomas have been reported with prolonged use of oral contraceptive pills. Though they are benign, a rupture of hematoma can be fatal. But this is so rare that I mean, I have read about this. I've yet to see a hepatic adenoma, happening in a woman with combined pills. Maybe my experience is not enough. I've been working in gynecology 96 onwards. So I think 26 years is long enough, but then maybe I have to learn more. So I've yet to see this, but it can happen. I've read about deep venous thrombosis, thromboembolic phenomena happening with oral contraceptive pills. I've yet to see a case. So these are all theoretical risks. They can happen, but yes, the benefits are there in front of you immediately. She gets regular cycles, she gets less bleeding, and endometriosis pain reduces so drastically. The disease gets limited. Please believe in oral contraceptive pills as one of the wonders of pharmaceutical industries. Seriously, and that gives regular cycles. But please remember, the cycles are regular only as long as you give the pill, okay? Not forever. That's a mistake. A lot of you, in your clinics, you are somehow taught this, that, if you give for 6 months, after that her cycles will be regular for the rest of her life. First of all, she's not going to menstruate for the rest of her life. She's going to menstruate only for 45 years or 46 years. And yes, the moment you stop the pills, within 1 or 2 months, she's going to go back to the irregular cycles. Correct the disorder. The pills is just an artificial menstruation. Okay, the pill is under my control. She's getting periods because of my tablet. Okay, enough about this. Gallstones are reported, but not gallbladder cancer. This is your surgery MCQ. In your surgery, they ask you this: which of the following is not implicated in the etiology of gallbladder cancer? Combined oral contraceptive pills do not cause gallbladder cancer, but yes, they do cause gallbladder stones, the smooth types. Yes, gallbladder cancer can be because of the mixed stones and the pigment stones. That correlation, I'm sure the surgeons would have taught you much better than what I'm saying. But yes, it's not because of the smooth stones which are caused by OC pills. So we'll move on. Yeah, we're getting into something about hirsutism. So I'll just see a couple of questions if you have something. Okay. Okay, Dr. Dubey, we'll get back to all of that. For the timing, we'll get into the questions. A 24-year-old girl presents with excessive hair growth on the face and upper back. A scoring was done, and this comes to a total of 11. So a girl has got excessive hair growth. She's come and complains about, not liking the hair growth on her body. So we are talking about hirsutism. And when we talk about hirsutism, somebody did a scoring of hirsutism. What is a score commonly used? Look, I know only of the Ferriman-Galloway scoring. As a clinician, we see these, and the Ferriman-Galloway scoring is the one which is used. I'm sure most of you got it. Yes, of course, the Bishop score is for the cervix, CXM writing for cervix and station of the head. When we say the cervix and the station of head, there are 5 parameters. So Bishop score is to know whether the patient can go into labor now or she'll take time. And please read about Bishop score, all of you guys, because Bishop score, they gave you the choice in your PG entrance question last time, that if the cervix is dilated 2 centimeters and the station is -2 and the cervix is soft and it is anterior, what is the Bishop score? All right. So score less than 5 is a poor Bishop. A score more than equal to 9, so we say 5 to 8 is obstetrician's decision. When I see a woman who is come to me and says, sir, I want to deliver, and I'm 38 weeks now and I don't know when I'm going to deliver. I have this uncertainty because I have a marriage in the house next week. Can I go and move around? So I don't know when I'm going to deliver. So I do a PVNC. Your Bishop says like, you're only 3 bishops, you're going to take time. You can attend the marriage and come back next week to the OPD. Another woman I see, the Bishop says like 9, 10. Please don't go anywhere, you may deliver tonight or tomorrow. So the Bishop score can tell us that. But yes, 5 to 8 is my decision. The obstetrician decides whether I can induce or continue for some time depending on the disease. Like a woman has hypertension and she's like 38 weeks of pregnancy, and I want to deliver her now, and the Bishop's is only 5 or 6. It's not great, but yes, it's not too bad. So I can induce labor, I can augment labor, I can induce labor with things like prostaglandins or oxytocin or stretching of the cervix and physical methods. I can induce labor. 5 to 8 is the obstetrician's prerogative to decide. So a good Bishops and a bad Bishops. Rotterdam criteria, all of you know, is for the PCOS. It's a place in Europe Rotterdam, where the criteria for PCOS was first laid down, and we know that it is about ovulation and Hirsutism, and along with that ultrasound picture of PCOS. So this Rotterdam criteria is now accepted by all the major societies, whether it's the American Society or it's the Androgen Excess Society or the European Society, Indian Society. Everybody accepts the same criteria. Whatever recommendations are coming are almost the same as the Rotterdam criteria. So that's why Rotterdam word is still used. But the three things which I told you, any two of them is PCOS. Now, Ferriman-Gallwey is the score. American Fertility Society score is not the one which we are using. AFS score is used for many things. One of them is endometriosis actually. So, maybe not a very great choice, but you know the answer is Ferriman-Gallwey score. So, in this we give a score to 9 parts of the body where women usually don't have thick hair. You know, try and understand, hair is there, hair is there everywhere on the body. So it's just that we don't see it so much, you know. Like I always tell you, there's a difference between the thin hair and the thick hair. Men have got a lot of terminal hair, thick hair, dark hair. Women have soft hair and light color hair and thin hair. So in a man who doesn't shave, you can see bristles within 2 days and a stubble. A woman, if you see closely also, you cannot see hair too easily. You can sometimes just see body colored hair on the face of a woman, and that's what is known as the vellus hair. So thin hair and light color hair. So that is what is vellus hair. Now, women having prominent hair on the parts of the body where she doesn't like them, like the chin and the upper lip and intermammary area and the chest and the abdomen, the back of the back of the patient, upper back, lower back, like that we have these areas. So each site which I'm talking has got a score from 0 to 4. So let's see this. A score of 0 is good, and score of more than 8 is Hirsutism. A maximum score is of 36. So more than equal to 8 by the Ferriman-Gallwey. This is a PG entrance question. It has come. How do you characterize Hirsutism? It is done by the Ferriman-Gallwey scoring. This was your question. They have not asked you how to score it. So maybe we can just see, if at all they ask you this time, there's no stopping the people asking you from tough questions, because the easy ones you've been doing so many times. So yes, the upper lip is the first one, then it's the chin, then intermammary area, then the abdomen, lower abdomen and the pubic area, then the arms and the forearms, and then the thighs, back of the thighs, the back of the chest, upper part, and back of the chest, lower part, and the intergluteal area. So all of these are given, see, 1, 2, 3, 4. All of these given a score. All these sites are given a score. One thing I want you to see, people who are writing the PG entrance questions, please, there is no mention of the side locks and the eyebrows. So a lot of girls have thick eyebrows and prominent side locks. So please don't call them hirsute. That's just a normal variation, and that doesn't constitute hirsutism. Thick eyebrows and side locks. See, it's nowhere in the classification. So please, first of all, don't comment on girls. Okay, give them the privilege of doing what they want about themselves by their own free time with their own doctors and specialists and cosmetologists, and don't be rude to women. Okay. And yes, there's a thing about hirsutism in the society which is not addressed, and I take this opportunity that most people who have got body hair should consult and should meet gynecologists or endocrinologists or even dermatologists and get a consult done, and don't feel hesitant to approach this so that the femininity is taken care of. But yes, I am just suggesting. I'm not laying down any rules, because to each his own. If a person is comfortable the way she looks, then she's free to stay the way she is. I'm so sorry if I'm hurting anybody's sentiments here. So please, if there is hirsutism, it's better taken care of. That's my advice. That's my suggestion. Okay. So the score of more than 8 is known as hirsutism. Let's move on and say question number 6. A 17-year-old girl underwent a laparotomy for an ovarian mass. So yeah, now we are changing the topics a little bit. Contraception and hirsutism was done. So let me see some questions. If you have something interesting which we can take right now. Okay, withdrawal bleeding, right? Somebody is there. Hi. And okay, somebody's given an answer. Good. Most of you got the answers correct. So guys, you're basically chatting with yourselves. Some of you are asking questions. So I think I'll just move on with the discussion which we're having now. So I think you take this as an opportunity to say hi to all your friends who have not been in touch with you. That's also not bad. So keep listen to my answers at the same time. So 17-year-old girl underwent a laparotomy for an ovarian mass and histopathology showed Schiller-Duval bodies. Ovarian tumors, long chapter. I've tried my best to give abridged notes in the PrepLadder forum, and I've wherever we've done live classes, I've tried to give you handouts. Ovarian tumor, long chapter, tiring chapter. Please read it. They'll just pick up one question from anywhere. They'll just pick up one question from any part of ovarian tumors and trouble you. All the name things, Schiller-Duval bodies and the Walthard inclusions and the Rinke crystals and the Rokitansky protuberance in dermoids, anything named, they're very happy asking you guys. And if it is there in your Shaw's and Novak's, okay, forget Novak's. If it is there in your Shaw's, you must know it. There's no escaping ovarian tumors. It's a long, tiring chapter. Please find your time and read the notes at least, if not the whole book. It took me 10 days to read it in my MBBS. And I thought I could do it faster in PG. It took me 20 days in PG, maybe even more. So remember, the Schiller-Duval bodies is for the endodermal sinus tumor, like we say, which is also known as the yolk sac tumor. So it's a type of malignant germ cell tumors of the ovary. That is correct. It's derived from the yolk sac. Yes, it is called the yolk sac tumor. It is also called the endodermal sinus tumor. These are the synonyms. It produces HCG, which is a useful tumor marker. No, it does not make HCG. So that's what is the wrong answer. That is the answer here. That is, I mean to say. So this is not correct about the statement which was given. Surgical staging and unilateral salpingo-oophorectomy is generally the treatment of choice. Ovarian tumors, especially malignancies. Guys, please remember, we are not telling you to do hysterectomy and bilateral salpingo-oophorectomy. I have never said that, and I hope none of you have that idea. When there is an ovarian tumor and it's malignant, it's mostly a woman who's 55 to 75 years of age. There I say, do a staging laparotomy and do an optimal debulking. What is optimal debulking? That is, the ovary, the diseased ovary will come out. Obviously, if the other ovary is normal, that will also come out because it can have an ovarian cancer later. What are you going to do with the uterus when both the ovaries are out? So we do the hysterectomy and removal of the diseased ovary and the normal ovary. And whatever else is present, like there's a growth on the bowel, we can do a resection and anastomosis. There's a growth on the peritoneum, we can remove that. There's a growth on the liver. My surgeon friends can do a partial hepatectomy. I mean, they can take out part of the liver and the patient will do fine. So whatever is present, you should debulk it. That is what is known as optimal debulking. Sometimes growths are present at a place which you can't remove it, next to the aorta, and it's a 1 centimeter growth. Now can't do anything around that place because you can injure the aorta. So what we say, sometimes we may have to leave something behind. So whatever you have to leave behind should not be more than 1 to 1.5 centimeters in size. And rest all bulk disease should be removed. So then it is called optimal debulking. So when nothing is left or whatever is left is less than 1.5 centimeters, then the post-op chemotherapy is much more beneficial and it's much more complete treatment. If you have a tumor which is sitting on the aorta, it is sitting somewhere where you have to do a major dissection or the retroperitoneum and you cannot remove it, unresectable tumor, then the patient is doomed. All right. So optimal debulking is you remove all disease, and then for a 70-year-old woman, I told you the example. Now this is a 17-year-old girl. Now a 17-year-old girl, obviously you will take out just the ovary and leave the other ovary because she wants to now have a full life where she wants to have menstruation and she wants to have children. So we want the ovarian function and the uterine function. So for her, again, the treatment is again called staging, laparotomy and optimal debulking. The statement stays the same. But what is optimal debulking for this 17-year-old girl? For this 17-year-old girl, I'll do a unilateral debulking. All right? Unilateral oophorectomy, that's a better word. Maybe debulking is not the right word, but yes, one ovary I take out and save the other ovaries so that she can use it for menstruation and she can also use it for the purpose of giving eggs, for the purpose of pregnancy and making a family next. So that's the treatment. Now this is the Schiller-Duval body, cystic spaces lined by flattened epithelium. Yes, here flattened epithelium. This is that endodermal sinus. There's the sinus which is a long channel kind of thing. longish area which will be having cystic space. Along with that, there will be flattened epithelium around it. A tuft of vascular tissue is often seen. This is known as the Schiller-Duval body. You see this, see this? See this is classical. There is a space here which is lined by this is the epithelium here. Can you see this is the epithelium here, flattened cells, okay? And there is this, I'll try to show you once more. See this area here, this, that. So I don't know why did I mark this. So you see this cystic space, and it's got this flattened epithelium here, and it's got this vascular tissue within it. So that's the Schiller-Duval body. Now remember, when we talk about Schiller-Duval body, this is in endodermal sinus tumor or the yolk sac tumor. Endodermal sinus tumor, this is a malignancy, but it is not as common as the other malignancies of women, of ovarian tumors. So in ovarian tumors, the most common malignancy, no doubt about that, is a dysgerminoma. It's not the teratoma. Teratomas are mostly benign. 90% of teratomas are benign. They're known as dermoids. So most common malignancy of the germ cell type, most common malignancy of the germ cell type is the dysgerminoma. Of course, overall, the most common malignancy is the serous cyst adenocarcinoma. So overall, in ovarian tumors, it is the serous cyst adenocarcinoma. In germ cell tumors, it is the dysgerminoma, and then the malignant teratoma or the yolk sac tumor. Now, what does the yolk sac tumor make? Yolk sac tumor or the endodermal sinus tumor makes more of alpha fetoprotein and more of alpha 1 antitrypsin. Okay, and when I say embryonal tumor, embryonal tumor. Now the embryonal tumor, that will make more alpha fetoprotein and more HCG. So since alpha fetoprotein is seen in both of these are both from the yolk sac. It is known as endodermal sinus tumor, and one is known as the embryonal tumor. Both are from the yolk sac. So both will increase alpha fetoprotein. But yes, what is specific, they'll ask you. So for the endodermal sinus tumor, the specific is alpha 1 antitrypsin, and for the embryonal tumor, it is the HCG. So that's why when they asked you that it increases the HCG, choice C is the answer to this question, that we don't see HCG increasing in this tumor. All right, so let's see the next question. And while doing a laparoscopy, you see a woman who's got pelvic inflammatory disease. You're seeing this picture in the upper abdomen. So when you see this picture in the upper abdomen, can you see this strings here, these strands here, which are connecting the upper abdomen wall and the chest wall to the liver. So yes, I don't know whether you can make this out. This is the okay, I'll try to take this off again and show you. Yes. So this is the strand, okay. This strand is known as the violin string strands from the liver to the chest wall. So this is known as the violin string adhesions, which are seen in pelvic inflammatory disease. So all of the following are true except, now these adhesions can cause pain, may lead to right upper quadrant pain, and the pain may be referred to the shoulder or upper arm because it's close to the diaphragm. So the C3, the phrenic nerve distribution, you always know that this is going to cause some, whenever there's a lesion close to diaphragm, it causes the shoulder tip pain. Most commonly associated with tubercular salpingitis. Now this is where it is a wrong statement because it is generally associated with, yes, chlamydia and gonorrhea. It is not associated with tuberculosis. And pain simulates like cholecystitis, that is also correct. Okay, so why it is got, give me a moment, I must have pressed something. Right, so answer is C, Fitzhugh-Curtis syndrome, Wallen string adhesions in the pelvis and around the liver caused by gonococcal and chlamydial infections. Right, let's see. Another question. A lady with infertility undergoes a laparoscopy for the purpose of assessment of her pelvic anatomy. For tubal patency, a chromotubation involves pushing dye from a cannula in the cervix, which is observed to come out from the fallopian tube. Basically, this is what is a laparoscopy, and in the laparoscopy, what we do, we have this uterus seen from the top. You know, I put a scope like this, and I see the uterus with the scope, and then these are the fallopian tubes. So what we do, we put some dye. Now we generally put a blue dye, so that is what is asked here. It is known as the methylene blue. You know, a lot of time when you're not very careful and you ask the nurse to get the blue dye, please say methylene blue, because sometimes a new nurse who is posted might bring you something which is bluish and they'll get you something violet, and that's the gentian violet. It's not going to cause much problem, but then it's slightly more concentrated, maybe a little corrosive to the tubes. So yes, please don't mark gentian violet, please mark methylene blue. So what it does, when I put this dye, you know, I have a cannula in the cervix, and when I put this dye will go like this and it will collect into the pouch of Douglas, which I am seeing by the laparoscope. So I am looking at the uterus like this. When somebody is pushing the dye from below, my assistant or my fellow, somebody will be doing that. So let's see if this video is working well here. Yeah. So see this, the scope which I am having, it is in the pouch, and I am trying to show you the dye coming out from the left tube. But as usual, it will come out from the tube which I am not focusing on. It's already come from the right one. So there is some blue dye. Can you see? It's already there in this. And see on this left side also, see now the dye is coming out here. So that's the ovary, the white thing is the ovary, and when I am showing you the left tube, the one which I am moving, see now the dye is come out from here also. So the laparoscopy, if you see, it shows us the uterus properly, it shows me the tube properly, and it shows me, yeah, see, I am seeing the liver also. Can you see? There is the liver here, there is the liver, edge of the liver here. So when I see the edge of the liver also here, I can see for Wallen string adhesions, isn't it? That's where that picture was taken from a patient where we're doing a laparoscopy, the one just before this. So yes, the whole of abdominal anatomy can be seen nicely, and we can also see that the patient's tubes are patent, and they are also mobile, they are not stuck anywhere in adhesion. You know, I want the tube to have a peristalsis. So the peristalsis of the tube will be there only when it is free. So in this picture you saw, in this video you saw that the tubes were free. So we know that it will pick up the egg and transport it to towards the uterus easily. And if the tube is stuck, then we know that's why she was not probably conceiving. Why am I saying this? Because when you do a hysterosalpingography, a lot of people believe hysterosalpingography is the best investigation to assess the tubes. I beg to differ, please. Hysterosalpingography is a good preliminary workup of a woman. If you want to check tubes in a sasta manner, in a in a cheap manner where you don't give it's not much of it's not much of a procedure. You don't have to admit her. It's an outpatient procedure. You do the hysterosalpingography with some IV sedation. Mind you, in spite of the IV sedation, is extremely painful. So you may have to give a paracervical block. And a lot of people don't like it, and I personally don't like HSGs because they give a lot of discomfort to the woman. So we say better assessment of the tube and the uterus is by doing a laparoscopy, and in the same sitting I do a hysteroscopy. So you all know that the best assessment of the anatomy of a woman is by doing a laparoscopy and a hysteroscopy in the same setting. Never think of HSG as the best. HSG is a good preliminary investigation. I offer it to people who probably, I work in a missionary hospital, it's not very expensive, but then yes, it does, we do have to charge the patients to make ends meet in the hospital. So we'll have to understand that even if we do it free of charge, then I would want to do the laparoscopy rather than the hysteroscopy, because laparoscopy is a far more complete assessment of a woman. So yes, HSG is a good preliminary investigation, doesn't give us the full information. HSG just tells about the cavity of the uterus, it tells me about the patency of the tube. It doesn't tell me the relations in the pelvis at all. Right. So the answer to that was methylene blue dye test. Then, which of the following conditions require a serial determination of a pregnancy test? What do you mean by a serial determination of a pregnancy test? That is, why would you go on doing a pregnancy test? What are the conditions where you continuously would do a pregnancy test in all of these situations. So in RH compatibility, you don't have to do that. In molar pregnancy, that's where you have to do that, because you know the HCG is the follow-up for a molar pregnancy. When a woman is pregnant with a molar pregnancy, there is a high HCG. So at diagnosis of a vesicular mole, if HCG is more than 10 to the power 5 and the theca lutein cyst is more than 6 centimeters and there is a large uterus. Remember one thing, the uterus in vesicular mole, the size of the uterus is generally more than the period of gestation. So suppose the woman is pregnant for 8 weeks and she has a vesicular mole, the uterus might be good 16 weeks or 18 weeks sometimes, and you might be very worried. So whatever is the size, please don't get AIMS people, you know, the INI-CET people are very happy asking you this very simple question, vesicular mole, please read about this nicely and go. That what is the management of a uterus which is 30 week size, 28 week size, huge uterus with vesicular mole. It doesn't change the management. You always have to say the treatment of a vesicular mole is a suction evacuation. Don't be under any pressure. Suction evacuation, of course, I would always add oxytocin drip. I'll give oxytocin drip because the uterus bleeds a lot with these kind of vesicular molar evacuations. So the contractions of the uterus help reduce the bleeding and expelling of the vesicles which we're trying to take out by a suction. So suction evacuation, I did not say DNC. Look, anything in gynae, you will get away saying DNC, right? I agree. But in this one place, please say suction evacuation. After 1 week, I would want to see the uterus is completely evacuated. I'll do a check curettage. I'll do an ultrasound to see if there is something inside. But more importantly, I'll do a chest x-ray to see if there is any METs, because the most common size of METs in a case of choriocarcinoma is the lung. So always look at the lung once and do the HCG. HCG levels have to come down. We know the HCG levels will come down to normal levels. Normal HCG, okay, I'll write it in the next page. The normal HCG levels, 9 weeks in a case of a complete mole and 7 weeks in the case of a partial mole. And if you have information of 8 weeks and 6 weeks, then that is wrong. Okay, 9 weeks and 7 weeks is where the HCG levels come down to normal. Now, why did I write these three? At the diagnosis of a vesicular mole, if you see HCG more than 10 to the power 5, theca lutein cyst more than 6 centimeters and a large uterus, then it is more chance of choriocarcinoma. So this is what is the poor prognosis. I mean, if you see a large uterus, that's where I started telling you about the evacuation methods. If you see a large uterus, then keep a more strict follow-up. The HCG levels will come down in 9 weeks or 7 weeks, but they can rise up again. Why can they rise up again? Because there might be a persistence of the trophoblastic tissues. So when the vesicular mole persists, the trophoblastic tissues, they can be a problem of a choriocarcinoma. But yes, you also know they can be a problem of an invasive mole, and you know they can also be a problem of a placental site trophoblastic tumor. So invasive mole, yes, it is the more common. It is the more common end of complication of a vesicular mole more than choriocarcinoma. But then we are worried more about choriocarcinoma, and this choriocarcinoma, the follow-up is by the HCG levels, which we are seeing. Invasive mole also HCG levels you can see, but classically for the choriocarcinoma, placental site trophoblastic tumor, it is from the cytotrophoblast. So since it is from the cytotrophoblast, it doesn't increase human chorionic gonadotrophin, it increases human plasma lactogen. So that's also one MCQ for the PG entrance students, that human plasma lactogen is the follow-up of a plasma-side trophoblastic tumor. And the treatment of an invasive mole, this is treated by surgery, and plasma-side trophoblastic tumor treated by surgery. And a choriocarcinoma, you can do surgery. If the woman is older than 40 years, I can go ahead and do a hysterectomy in a choriocarcinoma also. But please remember, a choriocarcinoma is wonderfully treated by chemotherapy. Please read about methotrexate and choriocarcinoma. It's a wonderful chapter, a little tough, but then remember this one chart which I've given you. I'll just add some more bits to this chart. And remember, the choriocarcinoma has excellent remission with methotrexate or the methotrexate, actinomycin and cyclophosphamide combination, or the EMACO regime for the meds and the high risk. Whatever you do, choriocarcinoma you should be able to treat so well that the woman has a normal uterus. As I'm speaking to you, I'm remembering a lot of young women whom we treated with chemotherapy, and they have a normal uterus, and they could use that uterus for a pregnancy even when they had a cancer before, which was totally taken care of, and now they have their own children. So that's why this choriocarcinoma, not that it's a good cancer to have, but it's one of the better cancers to have because it's got a good treatment with chemo. So yes, treatment is chemotherapy for a choriocarcinoma, but then surgery is also a good option if the woman is older. Now, what I wanted to add in this, I wanted to add that if a woman has a choriocarcinoma, it's mostly because of vesicular mole, but it can also follow a normal pregnancy. Please understand this. The vesicular mole has persistence of trophoblastic tissue. So pregnancy also has trophoblastic tissue, the syncytotrophoblast and the cytotrophoblast. So that can also cause all of these results, all of these complications, and so can an abortion. An abortion can also cause these. So these are the benign trophoblastic conditions. Benign trophoblastic conditions. These three, the pregnancy, abortion and the vesicular mole, and these are the gestational trophoblastic tumors, or some people call it gestational trophoblastic neoplasms. So please remember this diagram, and there is one exception to this diagram, you know, the right hand side and the left hand side. Please remember that invasive mole does not follow a normal pregnancy. People writing the PG entrance exam, remember that vesicular mole and all the complications and problem of choriocarcinomas and even the WHO prognostic scoring is part of your understanding for this. So please find time and read all the parameters of WHO prognostic scoring. Okay, so I've discussed a lot of theory in this part of the questions, but I think it's important that you remember this bit. Also remember that these three can cause all of these, but remember, when normal pregnancy causes choriocarcinoma, it's worse. Normal pregnancy causing choriocarcinoma is worse than a vesicular mole or an abortion causing choriocarcinoma. That's the punchline which I wanted to give you. That's why I told you all of these problems and their results. Fine. According to recent updates of the MTP Act in 2021, March 2021, a registered medical practitioner can terminate pregnancy up to how many weeks? So guys, you know this one very well. Now everybody was looking up to this, and wherever I've taught you that we could do it only to 20 weeks. And there was a proposal for 24 weeks. Now the proposal has been more than a year now, where the President of India has signed on the bill. So it's approved now. The latest amendment of MTP bill, which was first made, you know, it was MTP bill was passed in 1971, and 72 onwards there are amendments coming to it. But out of all the amendments, the one which interests us, and it's already been asked as a question, is that when was the latest amendment made? 2021 March, and this says that now we can do MTPs till 24 weeks. Now the problem is, who can do it? So far only gynecologists can do it, or doctors who are trained in gynae, or doctors who have done 25 abortions under supervision. And so far all the other talk of the other specialties and the other types of medicine, people from that, whether can they be allowed to do MTPs, all that is still a talk. So let's not get into that confusion at all. For your PG entrance exam, you need to understand this much, that only a doctor with a DNB or a DGO or a MD in gynae can do the MTPs, or people who are trained in gynae for 6 months or have done 25 abortions under supervision until 24 weeks. Now, let us show you the Gazette, and this Gazette, this was Act of 2021. It was dated 25th March. So, you know about the Act, and this is the Gazette of India. And it now says that subject to the provision, etc., a pregnancy may be terminated by a registered medical practitioner where the length of the pregnancy does not exceed 20 weeks. Next line, where the length of the pregnancy exceeds 20 weeks but does not exceed 24 weeks in case of such category of women, as may be prescribed by rules made under the Act, if not less than 2 registered medical practitioners are part of the decision making procedure. So, the gist is 20 weeks, one doctor can decide. Earlier it was 12 weeks, one doctor can decide. After 12 weeks, 2 doctors. Now, till 20 weeks, one doctor can decide the conduct and management of a medical termination of pregnancy. After 20 to 24 weeks, 2 doctors should decide what is the best method and observe her. Something goes wrong, 2 minds are better than 1. Like that we say, because 20 to 24 weeks, if you're doing an abortion, it can bleed a lot. Any abortion can bleed a lot. Any abortion can have septic induced abortion. Please be very careful of doing abortions, guys. I'm so sorry that most of you interns and immediate post interns do tend to give this advice to your non-medical friends, and you tell them, those non-medical relatives especially, you give this advice, and do me a favor, please don't do that. I mean, like, you guys can get into trouble. I mean, before you become postgraduates, you could get into some legal troubles. A woman who has a complication with the medical termination of pregnancy, if I do an MTP, even I can go wrong. I told you I have some experience now, but then after having this 26 years of experience, one thing which I'm even scared of now, after doing all the major surgeries in my life, I'm still scared of doing medical termination of pregnancies, because any MTP can go wrong and a woman can get extremely sick. And I may just get a rap on my fingers that, Dr. Vij, you should have been careful. This happened because of your mismanagement of the MTP. Be careful next time. I can get a rap. In spite of me being a head of the department wherever I'm working, I can get a rap on my fingers by the government or by my institute. I may survive. I may pull through because I have a degree and I have this experience. But you guys, if you do this and if somebody gets behind you, you had it. MTP and a woman gets very sick, or they can die. Wherever you interns have worked, I'm sure that in all your ICUs, at the corner of the ICU, there'll be one woman who's having a septic induced abortion, and you know that she will be very, very sick, and you'll be spending your whole night trying to resuscitate her and help her, and your PGs and your medicine people helping you, and the surgeons helping you with the laparotomy, and so many things would have happened, and you will ultimately lose her. It does happen many times in our country now. It is reduced, but please, don't wait for that complication. Even something which is troubling her so much that she has to come to the OPD after the MTP, that is enough indication for you that you should not put your head into MTPs till you become a specialist in gynae or you're trained in gynae. So that was a personal advice, and since being in the practice, I see a lot of young doctors trying to help their friends. Your intentions are correct, but your methods are wrong. Please take help from your seniors. There are gynecologists everywhere. Gynecologists are the commonest variety of doctors, specialized doctors in the country. I'm sure there are tons of gynecologists wherever you're working. Please take help of one of the senior gynecologists and help your friends or relatives who want an MTP. And medical drugs used for the management of MTPs, the mifepristone and the misoprostol, please, that is the one which is misused most. I'm being very frank here. Please be at least careful of giving the mifepristone orally and the misoprostol vaginally. That has been messed up, and a lot of women come to me as complications where they've had 4 tablets of misoprostol and put 1 tablet of mifepristone in the vagina, and that gives a lot of gut crampy pain in the gut, and abdominal cramps and vomiting and diarrhea. Apart from the bleeding, all these complications also happen. So I'm taking this opportunity to request you guys not to get into trouble for yourself and of course for the patient also. So that's the talk about MTP. Now we can do it till 24 weeks. Yeah, there was one more this question that if you can do till 24 weeks, 2 doctors should be there. If you find a disorder after 24 weeks until 28, 28 is viability. So from 24 to 28, what do you do? Now 24 to 28 weeks. Yes, there's a provision in the law now which says get an approval from a state board A state board shall decide. Now, approval from a state board is like, there's a body of doctors and social activists, or one person from the government along with a gynecologist, pediatrician and a surgeon, who will say that, okay, fine, on the ultrasound you see this defect and this is not viable with the life, so yes, you can go ahead and do an abortion. So after 24, some women will come to you very late and you diagnose a non-viable kind of a disorder at 26, 27 weeks. There's an encephaly. Suppose you see an encephaly only at 27 weeks. You cannot do an abortion. No, you can't. You will have to wait for the labor to go in. You cannot kill that baby, please. Now, the board knows that yes, this anencephaly baby is not going to make it. Whatever happens, it's not going to make it. So still for that anencephaly, you need to have approval from the board. So anytime after 24 weeks to 28 weeks, if you want to do an abortion, get approval from the board. Otherwise, MTPs can be done only till 24 weeks. All right, no confusions. Let's move on. I know you must be having a lot of questions. You must be there on your mind here. 24, 20 spheres, only gynae. Okay, a lot of answers, not much questions. Right, Ms. Vij, thanks for your comment. And let's move on. Which of the following is an absolute contraindication to an IUCD insertion? Now, what happens in an IUCD insertion? That a lot of us have a misconception that IUCD causes ectopic pregnancy. So, I'm giving the answer straight away. Please, IUCDs reduce pregnancies. IUCDs reduce ectopics. Please write this somewhere, guys. Please don't get into any other confusions. Let me read the answers and then we'll discuss once again. So, absolute contraindication to IUCD insertion is not HIV positive status. This is not a contraindication. Previous ectopic pregnancy, now this is where you're going to get bugged with me. It is not a contraindication. History of previous PID is not. Current PID is an indication for not giving. I mean, don't give IUCD if she's having an infection now. You understand that obviously. Unexplained vaginal bleeding, please do not give IUCD because it's going to only increase the bleeding. What is the most common side effect of an IUCD insertion? Yes, all of us know IUCD insertions mostly cause excess bleeding for the first 3-4 periods, and she's already having a problem bleeding. Please don't go ahead. Find out what's the cause of the abnormal bleeding and then only give this IUCD insertion. Now, when we see IUCD insertion, any contraceptive effect, we have this classification that medical eligibility criteria for giving any contraception. So, MEC1 is a condition which is no restriction for the use of contraception. MEC2 is a condition where there is advantage of using the method generally outweighing the theoretical or proven risks. MEC3, condition where the theoretical risk is usually overweighing the advantage of using the method. And MEC4, condition where there is an unacceptable health risk if the contraception method is used. Generally saying, any contraception, if they write next to it, it is a MEC1 or MEC2, go ahead and use it. MEC3 and MEC4, don't use it. That's the meaning of this chart which I give you. So, MEC1 and MEC2, PG entrance. Guys, please note this one. This is how they're going to ask you in exams. They're going to give MEC1 and MEC2, and if you're not knowing this method of classification, you may miss some marks here. So, MEC1 and MEC2 is how we categorize the contraceptions. Now, when we're talking about pelvic inflammatory diseases, see here, pelvic inflammatory disease, I means, I don't know whether you're able to see this. Let me stop this and restart. Once a minute. Discard and there we go again. I don't know why it is still coming. Yeah. So, pelvic inflammatory disease, I is for initiation, C is for continuity. So, pelvic inflammatory disease, past PID, there is 1-1. That means initiation, continuation, there is no problem. PID which is current, it is a contraindication. If she has a IUCD, you can continue probably, but if she has an IUCD, don't give her. She has a PID, don't insert a IUCD now because she already has an infection. Okay, so this is a contraindication I told you. Now, high risk of HIV, please note this. This is not a contraindication. You can give, the benefits are more than the risks. So, go ahead and give. Now, severe or advanced HIV with a clinical disease. Now this is a person you don't do anything for. Obviously, you'll not introduce an ICD. So this is a MEC3 avoid. In active HIV which has got a clinical disease. If she is HIV positive, that alone is not a contraindication. Okay, when we're talking about IUCDs. Now this is the one which is going to probably help you understand better. Post-abortion, immediate post-septic is a contraindication. MEC4 don't give, please, she's got a sepsis. But abortions, we can give ICDs, no problem. And the next one is the piece de resistance. Please understand. Past ectopic pregnancy, initiation, I is here and C, continuation is here. See, it is 1 and 1. Please, 1 means where there is no restriction for use of contraception. I am showing you again, past ectopic pregnancy is not a contraindication. Please remember, ectopic pregnancies can happen, but those are in the failures of IUCDs. Let me explain that to you. I'll take this opportunity to explain this yet again to all my friends here. When a woman is having an IUCD and when a woman is not having an IUCD, let's say this is a normal woman and this is a woman with an IUCD like here, okay, and this is a thread which is outside. Now, a normal woman who conceives and an IUCD woman who conceives. In a normal woman, the pregnancy will be in the uterus 99% of times. 1 to 2% ectopic is the incidence of ectopic pregnancies. All of us know that very well. Now, when a woman with IUCD conceives, first of all, IUCDs reduce pregnancies. Then IUCDs also reduce ectopic pregnancies. If at all she conceives, where would you find the pregnancy? Now that would be 95 times to 96 times still in the uterus. 5 to 6% might be in the fallopian tube. It's just that if a woman with IUCD conceives, rule out an ectopic. I did not say that IUCDs increase ectopic. Please, why will I say that? If I say that IUCD is going to cause an ectopic, why would any woman take an IUCD from me? It's one of the most favorite long-term contraceptions. You remember I told you, fill it and forget it. Once you put the IUCD inside, after that you don't have to worry about remembering of a contraceptive every time they have sex. For 5 years, she is free of remembering about contraception. So fill it and forget it. IUCD is one of the favorite long-term contraceptions, reversible type of contraception. Now, if I put an IUCD and tell the woman, and she'll obviously ask, is it going to cause me any problem? Yeah, it's going to cause an ectopic pregnancy, which is going to rupture and you're going to die. Who's going to take an IUCD from me then? Please, IUCDs do not cause ectopic pregnancies. Now, this is where a lot of understanding has to be there. I've given you some proofs from major recommendations from major institutes, their handouts, their books. I wish I could name the institutes, but please understand, this is important. You should know what is MEC 1, 2 and 3 and 4, and when we say previous ectopics and previous PIDs, they are not a contraindication. All right, let's move on. I know you will be probably asking me some questions here. Let me just see once. Excuse me. Jai Bhavan, I think you should read hard and not hope for the PG exam to be postponed, because why should we want? We've had 2 months of delay. I think all of you should get on with what is happening. I know you would want more time. Those who are still not finishing the internship in time, I'm feeling bad for them, but I think it's about time. 6 months to 8 months of difference is not going to make much difference in your long-term careers. After 10 years, the ones who are writing now and the ones who are writing next year, after 10 years, both of you are going to be surgeons or physicians, and it's not going to cause much problem in long term. But delaying an exam endlessly, my personal view is that it's been delayed enough. If you can get it delayed for another 1 month or so, God bless and wish you best luck. All right, so let's move on. Thanks for your comments, guys. Thank you. And Dr. Lulu. Can a nulliparous, I like this question. Dr. Divya Gopal, can nulliparous women opt for IUCD? I'm going to just nail this question. Please, when a woman is nulliparous, is it a contraindication for giving an IUCD? Now, this is what has been practiced in the country, that when a woman has never delivered, how can she have an IUCD going inside? So, if a woman first time, she has a cesarean section, okay, let's get back to this one. If a first time a woman had a cesarean section, okay, and the incision was here somewhere, and after the cesarean section, next she comes to the OPD after 6 weeks and says, I want a contraception, don't we put an IUCD in this woman? It's the same cervix which did not open. She's never opened the cervix. She had a cesarean section first time, and we put IUCDs for them regularly. So how did this cervix allow for this IUCD to go inside? It will obviously allow. There is no such problem. Don't you say one of the most effective methods of emergency contraception is IUCD? So you won't give it to a nulliparous woman. A woman who is 21 who's had sex and she comes to you after 4 days. So the only thing you can do at the 4th day after unprotected intercourse is give an IUCD. Now you're going to about to put an IUCD and you ask, oh, you've never delivered. I can't give you this method because you're a nulliparous woman. See, that's how I would like you to understand. I go the other way around to explain you things. So we do give IUCDs for nulliparous women, please. Nulliparous woman is no contraindication. How can that be? I mean, it's funny when you are told about that nulliparous woman cannot have IUCD. You know who's making the IUCDs? The Europeans and the Americans. They devise the best IUCDs in the whole world. All what we're following is what is done in their countries. They're the ones who devise the best methods and the best techniques and the best elements by which they're making the IUCDs. And so much research goes into making an IUCD in their countries. And when we use them, they themselves won't use it because Europeans and Americans, they have children very late. You know, they have children at 30, 35, 40 sometimes. So, you know that they are sexually active around 20 years or so. For 10 years, none of the Europeans and the Americans, they won't use IUCDs. Why? Because we are nulliparous. And nulliparous, it is contraindicated. So, how can I use this IUCD? So, let us make all the IUCDs and send them to India because they are multiparous women and they use the IUCDs. In the European and the American continent, the problem is that they are nulliparous women. We cannot use IUCDs. I don't know whether you like this or not, but please. That's the way I can explain things. IUCDs are used in nulliparous women very, very regularly. I don't know how many nulliparous women have put this IUCD, and every time I'm putting this IUCD in a nulliparous woman, I'm reminded of this question which people ask me. So, isn't it a contraindication? Please, it goes in smoothly. It's a very good contraception, and people tolerate it just as well. Okay? So, don't think of it. I know you're giving some comments here. Let me see. Yeah. Why it is not advisable, Dr. Vodeka Riai. I'm so sorry about the pronunciation. It's not. OHSS. So what? Just now I gave you the information that if she's had a cesarean, don't we give it again? I mean, if she had a cesarean, she's not delivered, don't we put it? We put it regularly. After 24 hours, nahi, Abhishek Verma, no, that's wrong. Till 120 hours. After 120 hours, you can't give contraception because that is 5 days. 6th day, implantation happens. So don't say after 120 hours. Before. So 5, please, I hope you're not saying contraception of choice is IUCDs. Please, emergency contraception. Guys, it's going to be a long theory class if you're saying all that. Hi, Paras. See, guys, emergency contraception. Now, that's one place where you people again get confused. What is the drug of choice for emergency contraception? I said the most effective method of emergency contraception in IUCD. What do you mean by effective? That IUCDs work with same efficiency, with same effect till 5 days of unprotected intercourse. IUCDs, when they are given, they will work for 5 days just as good they work on the first day. Suppose a woman had sex yesterday and today she comes to us and I put an IUCD, it will prevent a pregnancy. Just as well, it will prevent on the 5th day also because the effectiveness is the same. So 5th day, afterwards of 5th day, When does the implantation happen after the ovulation and embryo formation? It happens on the 6th day earliest. So you can give an IUCD till 5 days because implantation can happen on the 6th day. So you can't give IUCDs beyond that. Now why it is good? Because it is equally effective for the 5 days. One day if you give on the day 1 of unprotected intercourse, it is going to prevent a pregnancy 98-99% time. The same effectivity till the 5th day. If you give levonorgestrel I pill, it is 97, 96%, 98% on the first day. It reduced to around 80-85% the second day. It goes to around 65-70% on the third day. So first, second day, if you give levonorgestrel pill, the effectiveness reduces. But IUCD is equally effective for 5 days. But that doesn't make it the best method of, please, it is not the drug of choice for emergency contraception. Please remember, you might get some young teenagers who had sex, or young women who had sex, around a 20-year-old girl who had a first unplanned sexual exposure. Things happen these days. So this woman comes to me and says, I didn't want to have one, but I had sex, so she's a little guilty and she's a little afraid, and you want her to not have pregnancy. And she says, see, I don't want to have a pregnancy. Can you help me, doc? And I say, okay, fine, lie down. I'm going to open your vagina with a speculum and dilate your cervix and put inside a IUCD so that you don't conceive. And she's going to have a wide-eyed look on her face and say, doc, have you not read about emergency contraception? That I pill is going to be so easy for me? She knows it herself actually. You don't have to teach the community about I pill anymore. The levonorgestrel pill is indeed the drug of choice. There was a question in INI-CET. Please don't get that wrong. INI-CET, there was a question which said, which is the drug of choice in India for emergency contraception? And the answer was indeed the levonorgestrel. It was not ulipristal because it's not approved for that purpose in our country so far. So do not get into any misunderstanding. Levonorgestrel is the method of choice because it's over the counter. The woman can just go buy this tablet and she's protected. Rather than coming to a doctor with the first for a prescription for an IUCD, then a doctor to insert the IUCD, which is not so convenient. Yes, it is most effective. I agree, it is the most effective. But can you do it for everybody who's had unprotected intercourse? I mean, unprotected intercourse is happening very, very many times. I mean, you guys know that more than me, of course. It's nothing which is strange in the community anymore. So there is so much of unprotected intercourse and so much of regular intercourse happening. How many times are you going to insert an IUCD every time a person has unprotected sex? So that's why you have to have a practical knowledge of the subject. When you're working and when you're regularly seeing patients, these things, when you discuss with me, I'm so confident in telling you that please don't say IUCD is the method of choice. I hope I've used this 5 minutes, conducively for you guys. Okay, forget it. Exam postponing, we're not talking about that. After 6 days, we do abortion. Yeah, you can't do emergency conception. Right. Ulipristal up to 5 days, yes, correct, but it's not the method of choice. Okay, guys. I think all of you agree, levonorgestrel. Okay, fine. Good discussion. I think good interactive discussion because you asked me some questions. Now, on a histosalpingography, all of the following features are suggestive of a genital tuberculosis except lead pipe rigidity of the tubes with nodularity. Yes. Tobacco pouch appearance of the fallopian tube. Bilateral corneal block. All these three are correct. Multiple diverticula, that I have not seen much with tuberculosis. It's more with PID, and those are microscopic diverticulas. So yes, that is known as salpingitis ischemica nodosa. They can be diverticulitis with other PIDs and not with tubercular PID. So lead pipe rigidity of the tube, tobacco pouch appearance of the hydrosalpinx. What is a tobacco pouch? Yes, tobacco pouch is a pouch in which you can hold tobacco. This is the fallopian tube, and suppose this side has a hydrosalpinx. So this is the fimbria at the end of this big hydrosalpinx. So it does look like a bag in which you can hold some tobacco, you can hold some change, it's just like a pouch. So we call it a tobacco pouch, okay. So that's a tobacco pouch hydrosalpinx, a huge hydrosalpinx. Hydrosalpinx means fluid collection in the fallopian tube. So yes, in this one I'm not showing you hydrosalpinx, I'm showing you a tube which one of my patients here, see there is a bead here, there's a bead here, there's a bead here, and there is some beading here. So beaded tube, it is patent. There is some, look here, there is some amount of fluid, dye spill in this histosalpingogram. And yes, in this one also you will see some cobblestone appearance due to intraluminal scarring okay, and that is because of this tuberculosis. There might be a cobblestone appearance because in the lumen there might be some amount of dye going within the tube. So the circumference of the tube might have some calcifications. So calcific tube, rigid tube, tube having tobacco pouch, hydrosalpinx, that is classical, and the tube will be blocked. But diverticular is not looking like the great answer. Remember, all tuberculosis in the pelvis is secondary to tuberculosis from the lung. TB in the pelvis doesn't start because of a direct spread from anywhere, please. And you know it is not sexually transmitted, it is not transmitted by contact, nothing like that. Please don't get into vague kind of understanding. The primary focus is in the lung, you know that, and from there some bacilli can find their way. Some reactivation can happen when a person is immunosuppressed, and they can be tuberculosis at multiple sites in the body. You guys are experts in tuberculosis much more than I am. So yes, it always is a hematogenous spread to the pelvis, and it always starts in the fallopian tubes, in the endosalpinx. Endosalpingitis is the first event of tubercular PID. Endosalpingitis is the first event of tubercular PID, and then it comes to the uterus, rarely to the ovary. Yes, ovary can also have, but much rare. Okay. So that's about this HSG. Which of the following is the treatment for decubitus ulcer in a uterine prolapse? Now, decubitus ulcer, we must understand that the uterus, if we see, there's the vagina. Now the uterus has come out in a prolapse. So the uterus is outside, and now the vagina is like this here. So when you see the uterus now, the vagina, see the uterus has gone out of the vagina. So the uterus is hanging out. So the blood supply here. So this blood supply, the arterial blood supply is having a lot of pressure, 120/80. But the venous flow is only 30 to 40 millimeters of mercury. So what happens? The band, see, this is the uterus, this is the vagina. All of you know the uterus is on the top and vagina is here. So when the uterus goes out of the vagina like this vagina makes a tight band over this uterus which is hanging outside. So what happens? There is a venous congestion in this uterus which is hanging out now. So this venous congestion on the uterus, venous blood is deoxygenated. And this uterus which is between the legs, and it is rubbing between the legs, she sits on a chair, it rubs on her undergarments. So there might be some small erosions, and those erosions won't heal. Why won't they heal? Because the uterus is having venous congestion. Venous congestion is deoxygenated blood. So for healing, we need oxygenated uterus, or the blood supply should be, the arterial blood flow should come and the venous flow should go. But because of this band of the vagina on the uterus, the venous flow is extremely sluggish. So there is venous pooling in this uterus, deoxygenated blood. Small ulcers don't heal. So this small ulcers here, when they don't heal, we know that that's a decubitus ulcer. So what we do? We push this uterus back inside, we push this uterus back inside. So when you push this uterus back inside, we hold this uterus in place by a pessary, and that pessary will make sure the uterus doesn't come out. So how do you know that the pessary is adequate? Once you put the pessary, it should not be painful for the woman. Once the pessary is put, it should not be very big pessary, and it should be just the right size which makes sure she doesn't have pain, and when she coughs or she strains, the uterus doesn't come out. So that's the MCQ which has come in PG entrance at least twice. How do you know that the pessary which you've inserted is adequate treatment? You know it because the pessary will make sure the uterus stays inside, and on straining, the uterus doesn't come out. So yes, the pessary will help in healing. The symptoms will abate, that the uterus goes back inside, the uterus which was out, it will go back inside. So that dragging sensation and the bowel and bladder symptoms, they will all become better. She'll have a more dignified life, and she'll not be having trouble in urination and defecation. And also when the uterus goes back inside, the venous return happens properly, and the fresh arterial blood comes and healing happens. So what do? There is no pessary management written here. So what do? I push the uterus back inside with a pack. So that's why this packing is the answer here. Okay, push the uterus back inside with a pack, and that pack is generally a gauze or a roller gauze which is soaked in glycerin and acryflavin. That's what my local antiseptic like acryflavin plus glycerin soaked packing. So I use this to push the uterus back inside, and once I push the uterus back inside, then the uterus, just like the pessary, there will be relief, and I use a nice big roller gauze. I do it once a day so that this glycerin has a hygroscopic action. So that will, take out the edema from the uterus which was out. So that edema goes off, and the acrylflavin is a local antiseptic. But the major healing is because of the fresh blood which is coming and the venous blood which is going out faster from the uterus. So packing will help. Glycerin acrylflavin is just, even if you don't give glycerin acrylflavin, she will eventually heal. But yes, with the glycerin acrylflavin, the local infections and they'll become better. Okay, and the glycerin will take off the edema. So there is faster. So one of my patients who came to me around 3 weeks back, she had a very bad decubitus ulcer, and she was making one ulcer and then she was making another ulcer on the side. So that's a picture which I'm showing you here. If you can see here, that this woman has had you can see the one blister here, it became an ulcer. There is this congestion here, there is some ulcer here. So this woman had a lot of problem when she came to us, and what we did, we just did the packing. We did not do the surgery, because if you do the surgery on a uterus which is out like this and it's not having good blood supply, the ends of the vagina which you suture after the surgery and the pelvic floor repair which you do, you have to close the vagina eventually, isn't it? That area is not having much amount of blood flow because it was a deoxygenated vagina for such a long time. So why don't we do the surgery in this situation when the woman came to me? Because the healing won't be very good after the surgery. It's, you may talk to me logically and say, sir, the uterus is out anyway and there is an ulcer on the tip of the cervix. So when you're taking out the uterus, why do you want to heal it? Heal not just the ulcer, increase the blood supply to the uterus so the tissue oxygenation becomes better. So when I do the surgery and remove the uterus, the remaining ends of the tissues which you're going to close, the pelvic floor which you're going to repair, that should have a good healing. If this is deoxygenated tissues, if you do a surgery, all of that will burst open and she'll have a bowel hanging out of she might have an enterocele or a poor healing, or sometimes she may have a vault which will open up and the bowel will be hanging out. She'll come with a emergency sometimes like that. So please do not heal, do not do the surgery till the decubitus ulcer is healed. This woman has done very well. I mean, when she came to me, I forgot to take a picture. She's done very well. All of this is healed and we are planning the surgery about next week. So, I'm sorry for the numbering. The numbering is gone a little haywire here. So, a patient presented with pruritus in the vulva and discharge per vaginum. A pap smear done reveals the following. What do you think the patient is suffering from? So, on a pap smear, you see these organisms which are having this flagellum here. See this? There is this is not so brightly seen. The flagellum, see at the end of all of this, maybe a better picture would have been given. Yeah, see here. See, there's a flagellum at end of all of these. So these are the trichomonads, flagellates. When they move around in the vagina, they cause a lot of inflammation and a lot of itching, greenish yellow frothy discharge. And yes, this is what is known as trichomoniasis. All of you know that well. Please, PG entrance questions, one of the easiest things they're doing in gynecology for you. They're asking you clue cells, they're asking you trichomonads, they're asking you strawberry vagina, and of course they're asking you something called snowstorm appearance and vesicular mold. They're giving you some marks straight away. I'm talking about PG entrance questions. They're regularly coming in the exam just to make sure that you know these outright basics and you get your basic pass marks at least. So this is a good easy question, trichomoniasis, flagellates, and in this, please remember that 70% men would get to have trichomoniasis with just one exposure with an infective person. So we always say trichomoniasis, please treat the man and the woman. We don't say husband and wife because that's not a requirement to have intercourse anymore, I think. So we say you treat the man and the woman both when a person has trichomoniasis, and 60% coexist with bacterial vaginosis. So it's good that even if bacterial vaginosis is there, the treatment of trichomoniasis is metronidazole. I'm just writing metron here, metronidazole, okay, all right, and that is 400 milligrams twice a day, okay. Yes, the Indian pharmaceutical industry is making only 400 milligrams tablets. So the dosage is 500 milligrams twice a day. So I generally give it 400 milligrams BD. A lot of people want to give 400 milligrams thrice a day, but give 400 milligrams BD for around 5 to 7 days, and it's good treatment of 5 to 7 days of metronidazole is good treatment for both bacterial vaginosis and trichomoniasis. So both of them, they coexist. So that's why metronidazole is a good drug, and drug of choice for both of them is bacterial vaginosis and trichomoniasis is metronidazole. Motile trichomonads are seen under microscopy. If you put this one drop of this on the slides, you'll see motile trichomonads. Cuff cellulitis post-hysterectomy it causes premature rupture of membranes, it causes preterm labor, and it has a greenish yellow frothy discharge. Right, guys. Some question got missed, I think. So these are all the speculums. I beg your pardon. I'll just move on and see. This question is very important. A second gravida para 1 at term pregnancy is in labor and fetus is in occipito-posterior. The doctor tried to do a manual rotation to make the head occipito-anterior, but the procedure failed and the head stayed occipito-posterior. In what type of pelvis can you see failure of head rotation? Now, this is a question which can come in exams. Please, occipito-posterior, occipito-anterior towards the left. Okay, left occipito-anterior and left occipito-transverse is the most common position of the vertex, and left occipito-transverse is more common than left occipito-anterior at the brim of the pelvis. So, left occipito-transverse, left occipito-anterior, most common position. What is the most common malposition? Right occipito-posterior. So, when you see occipito-posterior, now let's see these pelvises. All of you know that the most common pelvis is the gynaecoid, and the second most common pelvis is the anthropoid, and the rarest pelvis is the platyploid. Now, when you see the gynaecoid pelvis, you see a nice well-rounded pelvis. So, if a baby is with the occiput, this arrow I'm trying to make, okay, I'll change the color. Okay, so if this arrow I'm trying to make like an occiput here, this arrow, it's in a gynaecoid, so it can rotate nicely and come and become occipito-anterior, no problem. Now, if there's an occipito-posterior in this, see, this is the arrowhead, is like, you can imagine that the arrowhead is the occiput. So, if it is occipito-posterior in anthropoid and there's an occipito-posterior in android, what happens in an occipito-posterior in anthropoid? Now, just see the characteristics of these pelvises. The anthropoid pelvis is narrow from the sides, see here. It's narrow from the sides. So, side walls are straight and convergent in the lower part of the pelvis. So, straight and convergent side walls in the anthropoid, and android, it is converging from the front. So, in the back of the pelvis there is a lot of space. So, this is the back of the pelvis, obviously, because there is a sacrum here, you can see. So, in the posterior part of the pelvis there is a lot of space, anterior part of the pelvis there is very less space. So, these are the two types of pelvis. In both of these you can see occipito-posterior and you can see occipito-posterior here. Now, when there is an occipito-posterior in the anthropoid pelvis, if it baby tries to rotate here, it cannot, because see, the side walls are so narrow. So, the rotation of the head cannot happen. So, that's the answer to this question. Whereas, in a case of android, this rotation is possible and it becomes occipito-transverse easily. Remaining rotation, you can hold the head. The obstetrician, if he recognizes the occipito-transverse, he can hold the head and rotate and make it anterior by his hand and quickly apply forceps and remove the baby, deliver the baby. So, yes, in an android, rotation is possible till half, it can become occipito-posterior, can become a occipito-transverse. You can complete the delivery by manual rotation, forceps, extraction. I've written a short form, manual rotation, forceps, extraction. But yes, please be careful. They may ask you a slightly different question sometimes. They may ask you that there's an occipito-transverse which is neglected for some time. The woman was in a village, she was brought to you after some time, and when she was brought to you, she was having an occipito-transverse for 4 hours, and the pelvis is now dry, the liquor is all drained out, the head is edematous, and the head is in occipito-transverse. Now, that is a deep transverse arrest because it is stuck there for a long time. Now, this deep transverse arrest, you may not be able to rotate it, you may not be able to hold the baby. So, if they ask you deep transverse arrest, they are trying to ask you that if it is a deep transverse arrest, they are trying to ask you to do a cesarean section. But yes, if you are in a labor room and you are the good obstetrician who is sitting with the patient and you note a occipital transverse in an android pelvis, you can hold the pelvis, you can hold the baby's head, rotate him to make it occipital anterior, and you can make him deliver normally by a forceps. Occipital posterior in anthropoid cannot rotate. It cannot rotate, and hence it delivers by face to pubis. So these are the questions which come in exams. Where is rotation possible? It is possible in gynecoid nicely. It is not possible in anthropoid. It can rotate half in a case of an android, remaining you have to do it with your hand. Okay? But if it is staying posterior, please remember, occipital posterior is a favorite question of the INI-CET, and they will always ask you, what is the fate of an occipital posterior? What should you do in the labor room? Wait and watch was the answer most of the times. Now this time they went a little ahead and they asked you this question, that if you can do a rotation, which one can you do? You can do it in a gynecoid, you can do it in an anthropoid, in an android, I'm sorry. You can do it in a gynecoid, you can do it in android. In an android, you can rotate it partly and rest. Half rotation happens by itself. The remaining you can do it by your hand, and you can apply forceps and take the baby out. That is in an android. Anthropoid, you cannot do it. So that's the answer to your question. In an anthropoid, there is no rotation possible. All right. So let us see this. I'm not able to read now. Let me just see if I can read from here. All of the following are true statements regarding the instrument shown here, except. All of the following are true statements regarding the instruments shown here, except. This instrument, it's a commercial instrument, so I've got a picture from their website. The IPAS manual vacuum aspirator plus. This aspirator is used for the purpose of suction evacuation by manually producing a vacuum. See, vacuum means you have to put a negative suction to take out the products of conception for doing an MTP. So generally we do suction evacuation till around 8 weeks to 10 weeks, and this one they say we can do up to 12 weeks, this manual vacuum aspiration. So this manual vacuum aspiration, you can see the syringe. When we pull the syringe, these two arms come out and they just hinge on the base. They will come out and they will hinge on the base of the hub of the syringe like this when you pull it out. So it will have a negative suction, and on top of that, on the top of this here, on top of this here, you can put the Carmel's cannula, and that Carmel's cannula will do the suction from the uterus. Please remember, the Carmel's cannula size is also a question which they ask you. The size of the Carmen cannula is the pregnancy in weeks. So if it is a 8 weeks pregnancy, the 8 French cannula you'll use, okay, and a bigger 10 weeks you use a 10 size Carmen's cannula, okay. So all of the following are correct, except it is used for MTPs till 12 weeks. Yes, manual vacuum aspiration can be done. You can do aspiration by a Carmen's cannula, and the suction can be made by a wall suction also, or from a machine which is generating suction. It's not that you must use only with the syringe. The convenience of the syringe is that you can do it in the OPD under local anesthesia. It's a OPD procedure with the syringe, and the pressure is around 600 millimeters of mercury, and the capacity is 60, can be used without electricity. So yes, this is correct. 12 weeks can be used without electricity. Obviously it's manual, it's used with a hand, and capacity is not 30 ml. This is the wrong. So except choice C, the capacity is 60 ml, and pressure generated is around 610 to 600 millimeters of negative pressure. 610 to 660 is the exact answer, which if at all they ask, around roughly 600 is fine. So this is the Carmen's cannula, and I told you about the size. This is the MVA syringe, capacity 600 ml, and suitable 5 to 12 weeks of gestation, and may be carried out in the OPD setting. Also there is electrical vacuum aspiration. So all that I told you, let's move on. Now, what type of fibroid is shown in the image below? Now please, FIGO classification. Please remember the International Federations of Gynecologists and Obstetricians. This classification of the fibroids, type 0 to type 8. Please find time and read it nicely, because they are asking you questions based on this. PG entrance questions. Definitely read about that classification. There's no escaping that. They'll ask you which one of these fibroids you can take out easily by a laparoscope. which one of these you can take out easily by a hysteroscope. So they'll just write the types, and if you don't know the types, you'll miss very easy questions in this manner. So obviously, if this is this one and this one, I can take out by a laparoscope, and this one I can take out by a hysteroscope. So those types. Anyway, what is the type of the fibroid shown in the image below? I think they are asking the one with this arrow. So this is the, you can see it's on the serosa, just stuck here. It is the subserosal fibroid, and this looks like a type 7, although there is no peduncle, there is no part in the muscle. So I will name it as a type 7. That's the subserosal fibroid. Now, pedunculated subserosal fibroid. Now what happens? What are the types of fibroid you can do laparoscopic myomectomy? So for a laparoscopic myomectomy, you can do for the type 7, type 6, type 5, type 4 also we have taken out so many times, but then you have to remember at least type 7 and type 6. Around 3 to 4 fibroids you can remove by a laparoscope, each less than equal to 5 centimeters. And hysteroscopic myomectomy, type 0, type 1, maybe also type 2. If you are well experienced, you can do that, but 0 and 1 you should know, and the size should be less than equal to 3 centimeters. Now, in laparoscopic myomectomy, 3 to 4 fibroids, each of less than 5 centimeters. But yes, if there is one big fibroid, then also you can do, but that should not be more than 15. So, or I'll add this here, or one fibroid less than equal to 15 centimeters. So these are the basic guidelines. Of course, we exceed them quite a few times, but then these are the safe guidelines. With experience, you can exceed. I mean, you can take out 7, 8 fibroids also so many times. But then yes, for the exams, you must remember 3 to 4 fibroids, each of less than 5 centimeters each, or one fibroid of less than equal to 15 centimeters. Now, this is one of the patients where I was doing, this was an open myomectomy because this was badly stuck, I would have, there's not just one fibroid to take out. See, there was this big one, subserous fibroid here. You can see the big peduncle. Now, this is the uterus. Now, the uterus itself is so big here. You see this patient which I was operating, there was this fibroid here, there was this another fibroid here, and there's another fibroid here. So, I would have done a lot of incisions to, laparoscopically it's very difficult to do tunneling incisions and take out more fibroids, or you should have a very good set of instruments, which is, every time new instrument comes out and you can buy them. So that kind of facilities are not there in most of the hospitals. So yes, regular laparoscopic work, I would have been happy if I had just this fibroid to take out, but this one we had to open up. This was way too big for us to manage laparoscopically. But yes, one of these probably I'll make a video and show you a lot of laparoscopic myomectomies and laparoscopic suturing. Very interesting. Get your PGs and then see those videos, okay? They're not going to ask you much about that. So, a woman at 37 weeks pregnancy, gravid to para 1 and previous LACS, presents with labor pains for the last 8 hours. 37 weeks, previous LACS, labor pains. So, somebody is doing a vaginal birth after cesarean. PG entrance students, please remember, they can also ask you trial of labor after cesarean. They can ask you this way also. So, on abdominal examination, there is tenderness in the suprapubic area and there is pervaginal bleeding. What is the likely cause? So, tenderness, when you palpate and you see, women may complain of pain when you palpate just above the symphysis pubis, you're supposed to look for scar tenderness. Which scar are you looking for? Not the abdominal scar. So, that's why you're putting your hand just above the symphysis pubis. Around that level is the cesarean section done. On the uterus, the incision is at the level just above the pubic symphysis. So, when I'm putting my hand on the abdomen of a woman who is in the labor room, I put my hand on the just above the pubic symphysis and distract her a little bit. I'll talk, okay, you'll deliver in some time, don't worry, everything is fine, your husband send a hi, and at the same time, I'm just looking for tenderness on the uterus, scar tenderness, and when every time I hold and she winces, I know there is scar tenderness. So, when there is scar tenderness, we know she is going into a impending rupture of the uterus. Please, this is MCQ, so I am telling you that there is a scar tenderness. Please, this should not discourage you from giving trial of normal vaginal delivery in a case of a previous cesarean. So, one previous cesarean, go ahead and give a trial of normal vaginal delivery. In fact, a lot of recommendations are there even for 2. but that's better in only institutional setups where senior doctors are present throughout the delivery. And yes, I know that up to 2 cesareans we can try and give normal vaginal delivery, but at least when they ask you a question, a woman had previous LSCS, what is the method if the baby is not too big, it's an average size baby and the woman's pelvis is adequate, please mark that we can give a trial of labor after cesarean or vaginal birth after cesarean, we can give a trial. Okay, the scar thickness on the ultrasound should be more than something like 2 millimeters to 4 millimeters at least. That will give us that this is not too thin. Can go ahead and give a trial. Okay, so this is impending uterine rupture. Answer is C. A routine question, very simple recall. Dose of carbetocin used in PPH management. Yes, this came in your exams and I hope all of you got that right. The dose is 100 micrograms in 1 ml given intravenous over 1 minute. Yes, it can be given IM also. So carbetocin is a synthetic analogue of oxytocin, and this has a better, longer action on the uterus. So you get effect of contraction of the uterus for a longer time. And my favorite, if I use carbetocin, I rather give it IM rather than give it IV, because that's my personal choice. But they've asked you about how to give it IV. 100 micrograms in 1 ml over 1 minute. Slow IV, okay, over 1 minute. A patient underwent internal iliac artery ligation for PPH. Later, she developed pain over the left uteral region. What was the injured artery? Now, internal iliac artery, the management for PPH, the anatomy, please find time and read it inside and out. It's not just coming in your INI-CET, it's coming in your NEET, and those of you who are from the MCI, it's coming for you guys also. This internal iliac artery has suddenly become a big, they've suddenly remembered that PPH management asks more questions about internal iliac artery. So all of you know that the internal iliac artery, all of these are the divisions. You know that this is the common iliac and this is the external iliac, this is the internal iliac, and under the inguinal canal, it becomes the femoral artery. You know that very well. But what are the branches of the anterior posterior? This question is outdated now. Nobody is asking that. It was a very easy question because you knew that the posterior division has 3 branches. I give you a mnemonic also, short gills. I always say that superior gluteal, iliolumbar, lateral sacral, short gills. Superior gluteal, iliolumbar, lateral sacral is the mnemonic by which you know the posterior division arteries. Now, by derivation, by deduction, you can say, okay, all of the following are the anterior division, all the following are posterior division. By exclusion, you can go and write this answer. So they are not asking this question because you remember only 3. Others you tell by exclusion. Yes, anterior division are more branches, so nobody wants to remember them. Now they're getting very smart. They're asking you a question first. What is the principle of internal iliac artery ligation? Please remember, when we do internal iliac artery ligation, we are not ligating the artery at its beginning. We are not ligating here. We are not ligating here. We are ligating the artery here. Only the anterior division. We are not ligating the posterior division, guys. Only the anterior division is ligated. And it's not a ligature which is very tight. It's not to just squeeze the artery and completely and obliterate it. It is just a comfortable ligature. It's a snug ligature just to stop, not to stop, just to reduce the flow. The ligature, when we're doing on the anterior division of the internal iliac artery, is to reduce the flow, not to stop the flow. So we ligate the anterior division to reduce the pulse pressure. Reduce the pulse pressure of this artery. So that causes sluggish flow. It causes sluggish flow. So sluggish flow in the uterine bed. In the uterine bed there is sluggish flow, and that sluggish flow promotes thrombosis. So thrombosis will stop the bleeding. So that's the mechanism. We are not totally obliterating this anterior division. We are just putting a snug ligature tight enough to reduce the flow, not to stop the flow. Now that's the principle. We used to always teach you this much, tell you the arteries and go away. Now they became very smart. They asked you a question which was applied, that you're doing the internal iliac artery ligation and she comes to you with the back pain. Okay, the question is, she develops pain over the left gluteal region. What was the injured artery? So they give you the hint that you ligated the superior gluteal artery by mistake, which is part of the posterior division. So So if you ligate the posterior region by mistake or intentionally, the patient is going to have lesser blood supply to the gluteus maximus, also to the sciatic nerve, which is partly supplied by the gluteal artery. So there will be pain on the left gluteal area, also radiating towards the thigh. Okay, so please find time. They asked you another question this time in I think INI-CET. What is the series of devascularization of the uterus while managing PPH? Just more fancy name for the same purpose, internal iliac artery ligation, isn't it? What is the chain of devascularization? Devascularization. What is the meaning? That how do you devascularize the uterus? First we ligate first is always the uterine artery, and then if this doesn't work, there's a good anastomosis with the ovarian artery, so ligate that, and then the third is the internal iliac artery. So when we say internal iliac artery, we mean the anterior division. Guys, which of the following women with biconate uterus would most likely benefit from metroplasty unification surgery? So biconate uterus is one of those conditions where the pregnancies will go till term. There might be a transverse lie or a breach. Rarely it causes preterm labor also, but mostly a biconate uterus, which is like this. A biconate uterus will have a pregnancy which will go till term. I will do a cesarean section, or if it's a breach, I'll do a normal vaginal delivery, and I am able to give a live baby to the mother. So generally I don't disturb a biconate uterus. We don't do surgical correction at all. Now, primary infertility is not a presentation. Heavy menstrual bleeding is not a presentation. Associated vaginal atresia, you will not do anything because there is a vaginal atresia, so it's not indication for. The indication is to join the uterus with the artificial vagina which you will make. So that is also not the one. So the only place where you do the unification of the biconate uterus is a woman with early recurrent pregnancy loss. So only indication, okay, biconate uterus unification, recurrent pregnancy loss. So if you see the biconate uterus is like this. See, normal uterus is something like this. If there's a biconate uterus like this biconate uterus, you will cut this margin and suture it together to make a uterine cavity like this. To make a uterine cavity like this, you must do a surgical correction. So that's what we are showing you here, that we make an incision here, then we make an incision here. So now these are the cut ends. Can you see here and here? They are the cut ends, and then you start suturing this to this. You put this to this sutures like this. See, that's what they're doing here, and then the uterus closes up and looks normal. So this is the Strassman's metroplasty. A female undergoing IVF was given injection HCG for ovulation trigger. Now presents with nausea, vomiting and headache. The USG of the pelvis shows some ascites and the ovary looks like the major image shown. What is the most probable diagnosis? So now this is not a serous cystadenoma. Serous cystadenoma is a unilocular cyst. This is not a theca lutein cyst because that is also unilocular, one big cyst. Ovarian hyperstimulation syndrome and PCOS are the choices. And I'm sure all of you understand that in PCOS you see multiple small follicles in the periphery. These are the two choices in which you may get confused. PCOS ovaries looks like this. They have multiple small follicles. Some of the time we'll discuss PCOS. There's a lot of material on the internet from PrepLadder, and one of them is my lectures. And please find time and read about PCOS again. We've done a big long discussion on that. So please do have patience and read that lecture. PCOS, a lot of doubts are cleared there. But yes, PCOS is an ovary with small follicles. Now this woman has got multiple big follicles. See, they are big follicles. So yes, I will definitely say that a PCOS woman can have this picture when we give her IVF stimulation with injection FSH. PCOS women have more likely to end up in this picture. Yes, this picture is ovarian hyperstimulation syndrome. More than 20 eggs in the woman, lot of estradiol and lot of HCG makes the woman become to have leaky blood vessels. Leaky blood vessels and the fluids start going out. So I made a pathophysiology and I've just taken a picture of that straight away so that you know in PCOS high incidence of OHSS. Okay, this is definitely the answer. Answer is OHSS. PCOS women have more chance. So when you give high HCG, more eggs are made. See 1, 2, 3, 4, 5, 6, 7, 8. This is just the 2 dimension which I'm showing you. Behind they be more. So more estrogen, more vascular endothelial growth factor, That will increase the vascular permeability. So when the vascular permeability increases, like see this is a normal vessel, now the fluids go out, and now you see in this woman there is hemoconcentration. And the fluids when they go out, they will make ascites, pleural effusion, pericardial effusion and edema. So hemoconcentration, third space collections can happen. Now this big ovary can undergo a torsion. You must understand that the ovary is normally just around 3 centimeters to 3.5 into 2.5 centimeters. Now this ovary has become so huge with multiple small, with big follicles of OHSS. So this ovary can turn here, it can turn here and have a torsion. So torsion, rupture, hemorrhage, and that can also cause death. So these are the three things which can happen: torsion, rupture, hemorrhage and death. Hemoconcentration and deep venous thrombosis, renal emboli, liver emboli, cardiac emboli and death. And then there can be fluid collections causing severe tense ascites, causing pleural effusion. Both of these will contribute to respiratory distress and then can cause death. So that's the worst case scenario, PCOS having OHSS. Now OHSS can be fatal also, but mostly it is the mild and the moderate forms. So most common cause of OHSS is actually clomiphene citrate, but this is the mild variety. The mild variety or the moderate variety might be there with clomiphene citrate. The ones which cause the severe variety of OHSS is injections FSH, that causes the severe and critical ovarian hyperstimulation syndrome. All right. Right. Which of the following is indication for surgery in ectopic pregnancy for a woman who is desirous of another pregnancy? Now, when a woman is having an ectopic pregnancy and she wants to have another pregnancy, remember, we'll try to save the tube. See, let's see condition 1. There's a woman who's got a fallopian tube which is ruptured, and there's a lot of blood here in the abdomen because of a ruptured tube. In ruptured ectopic pregnancy, you have to do cutting of this tube and throwing it off. Total salpingectomy, guys. Ruptured ectopic, total salpingectomy. Now, if the tube is not ruptured, you will try to save the tube. Yes, you will try to save the tube, because if the tube is ruptured, then it is worth only the dustbin. You have to do a salpingectomy and throw it. But if it is unruptured, then you can save the tube by taking out the fetus. So that is what is known as a linear salpingostomy surgical method, or you can kill the fetus by methotrexate. So medical management, surgical management. So the criteria is medical management. Say for example, I can use methotrexate or potassium chloride, and surgical management is a linear salpingostomy, or we can do resection, anastomosis of the tube. So either I can do a linear salpingostomy, I can make an incision on the fallopian tube like this and take the baby out here. That is a linear salpingostomy. You know, there's a uterus here and this is the fallopian tube. This is the bulge of the ectopic pregnancy. So I can make a vertical incision here. I can make an incision here, and this incision, linear lengthwise incision, open this and the baby comes out. So linear salpingostomy. Or you can cut the tube here and re-anastomose it. So ruptured tube, see, ruptured ectopic pregnancy, total removal, total salpingectomy. I'm sorry for the mess here. Total salpingectomy is the management. But when it is unruptured, I can do a salpingostomy, or I can do a resection and anastomosis to save the tube so that she can use it for a normal intrauterine pregnancy next time. So that's what is resection, anastomosis, linear salpingostomy, surgical, and this is the best surgical method is linear salpingostomy. In medical management, we have the methotrexate KCL. Methotrexate is the best management. Now, the criteria is based on size. Size, if it is 4 centimeters, less than 4 medical, more than 4 surgical. HCG 5000, less than 5000 and more than 5000. More than 5000 you cannot do medical management, do surgical management for better results. And cardiac activity, if it is absent or if it is present. If it is present, then we must do a surgical management. Excuse me guys, freezing here. Now, so based on this criteria, we will do medical or surgical management. Now, instruments used in a cesarean section. So, there were a lot of choices, A, B, C, and D, C, E, and F, A, M, F, A, C, like that. I am not going into all of that. I am just telling you what are the instruments used in a cesarean section. I am sure you will understand that way. So, yes, a Doyne's retractor is used. Now, that is the best friend of an intern. Those who have just done the internship, you will remember that very well. And those who have done the internship last year will remember it even more fondly, because that is the retractor which is part of your body in obs and gynae. You are holding on to the retractor for dear life. Well, when gynecologist is operating, you are just stuck with the retractor against the symphysis pubis, and you are retracting the bladder with that. So, the Doyne's retractor is correct. Alice forceps is generally used for holding the ankles when there is bleeding. Of course, the better instrument is the green Armitage forceps. So, yes, green Armitage forceps is the one which is used for holding the angles of the uterus. Bart Parker handle and blade, obviously that is the one which we use. The Bart Parker is the handle on which you put that blade for the surgery, any surgery. So, yeah, that is correct. Common cannula, obviously not. Cusco-vaginal retractor, cusco-vaginal is the biwall speculum, something like this. It opens up in the vagina and open the vagina, and you can see things inside, and you can do minor surgeries. That is not the answer here. And Shirodkar retractor is used for myomectomies. Probably I will show that to you sometime. So, yes, this is the answer. So, this is the green Armitage, see this flat serrated, and serrated. See this serrations here. So, this is a flat tip which is serrated. So, this we put on the angle, and this will hold the uterine artery nicely when there is bleeding. So, holding the angles of the uterine incision, not of the abdominal incision. Green Armitage. Green Armitage was a doctor. He worked in British India, and then after independence, when independence was declared, he went off to UK, and he was associated with the Royal College. He was the head of the Royal College sometimes. Extremely good obstetrician, Green Armitage. Many things are attributed to him. One of them is the green Armitage forceps. Okay. So, this is the picture of the green Armitage. Now, this is the Alice forceps. Of course, Alice forceps is used for surgery also, general surgery. It is also used for holding the rectus sheath, you know that, and it will hurt. Okay. So, those of you going to become surgeons, yes, gynecologists, general surgeons, orthopedicians, and when you want to check for anesthesia on the skin when you give local block, please do not use this instrument. This has got 4 teeth, it has got 3 to 4 teeth, and if you use this to hold on the skin, and even if she is not, she has got a good anesthesia, she is having good local block, even if she is not going to have pain, but you are going to hold the skin and test with this, it is going to make a big bruise on her. When post-op, you see wherever you use the Alice forceps to check, there will be marks. So, just use the thumb forceps, it has got just 2 pincers. So, those thumb forceps you can use for checking the block. Okay, do not use this on the skin, please. Alice on the skin means if you have a surgeon teacher, if you have a good gynecologist who is a good surgeon, he will get very upset with you if you use Alice on the skin. Do not use that. It is used for the rectus, it is used for the angles of the uterus, yes, for tough tissues, not for delicate skin. So, this is the Doyne's retractor, yes, best friend of the interns, always assisting caesareans, and thanks to all of you, we can do caesareans with a lot of good retraction of the bladder away from the field. This is that retractor, Doyne's retractor, and this is where it is applied in the uterus. This is that Cusco speculum, this is the Cusco speculum, alright. This is the Cusco speculum, alright, and I think that is it, but then I think I will show you the other speculums which were there, which one question got missed, I think somehow. So, I will just show you the speculums which were there. Why miss out on those? Yeah, this is also another type of Doyne's, and this is the Devers retractor. I wanted to show you this. Devers retractor is the one which is used in deep pelvic surgeries. When we are operating on the uterus, which is a little just behind the pubic symphysis, much deep in the pelvis, and you are having to ligate the uterine, so you are having to ligate the macronod ligaments. It is much too deep. And for retraction of the bladder, retraction of the bowel on the sides, this works nicely. Deep pelvic surgeries, this is one of our best friends, Devers retractor. So, right guys, a lot of discussion we had, and I tried to put in a lot of stuff. I am keeping this space here so that I can take some questions and write some things if it is required. So, let me just go back and see what all you guys have been asking me. There is a lot of chat. Let's see if I can answer a few questions at least. Okay, I've gone way back till the molar question. Okay. If you have something fresh, please start punching in your requests immediately, because I'll be eventually coming to the end now. Okay, and Jay Bhavani, you're not waiting for the postponement. You're going to read very well, and you're going to write this time, and you'll do well. Okay. No, I'm not from Kerala. Fadi, I'm so sorry about my iPad. I made this on my laptop, and I'm a total Windows guy, and iPad doesn't go well with me. I'm a novice with the iPad, and I just transferred it, and I did not see the sequencing of the questions. So I hope I hope the content interested you more than the sequencing. Apologies. Anis film reading correct? I'll simply finish it fast. Okay, ICD question was done, and MTP not corner. Okay, fine. This one we've done. We will be in Hyderabad. I was in Hyderabad so many times recently. Doc, do you have hyperopia? I don't know. I can still use my vision to see. I mean, I'm not having any lenses, so I'm able to manage well. One of these days, you become an ophthalmologist and give me a free consult, all right? That's the least you guys can do. And if I have a problem anywhere in the country, I hope all of you students are there to take care of me, okay? Whichever part of the country I'm having a problem. Via all these classes, I'm trying to invest into good health. So if I fall sick anywhere in your city, please be there to take a good, kind-hearted treatment for your gynecologist teacher. LNG dose is 1.5 milligrams. I did not write that. I'm so sorry. 1.5 milligrams, one tablet, okay? Earlier we used to give 0.75 milligrams, two tablets. It means the same. I don't know why this question was asked in exam. 1.5 is the right answer, correct. So, Anisur Rahman asked me a good question, that if the ovulation has already happened on the 14th day, if she has unsafe intercourse on the day 15, why won't it be? How can you give levonorgestrel? Yes, we can give, because levonorgestrel reduces the chances of ovulation, correct, but it also helps by making the tubal motility reduced, and the embryo comes too late for the implantation. Levonorgestrel is a high dose of progesterone. It also makes the endometrium too secretory and out of phase. The term is out of phase. You need the right amount of progesterone. When the implantation happens on the 6th day, you need the right kind of endometrium for the embryo to sit on and implant. Now, if you give high dose of levonorgestrel, this is 1.5 milligrams. Remember, this is 150 microgram. And the dose for occipils is 0.05, 0.15 milligrams of progesterone. So here I am giving much higher dose. So it will make the endometrium too secretory, and the pods for implantations are internalized. So that's why we say that it reduces implantation and it reduces the tubal motility, and that's why the embryo doesn't implant even if they have had intercourse after the date of ovulation. So good question. Somebody asked me this question. I'm so happy. Okay. Okay, levo dose. A lot of people asked. Why did I forget that? How do you revise effectively for INI-CET exam? Swati, please, whichever institute you are associated with or whichever app you are associated with, please read the notes. And for sense of completion of major subjects and in the minor subjects, you finish your notes and do the, our company is giving you the free lectures of all the exams for the last 3-4 years. All the exams, INI-CET, the JIPMA exam earlier, and the AIMS exam earlier, and last 2 years the INI-CET, the NEET exam and the MCI exam. Do all the questions. If you are a PG, also do MCI exam questions also, because questions have become very good. So if you want to suppose revise gynae, my answers, the way I teach with good explanations of all the MCQs which came in last 3-4 years, are there free on the YouTube. So if you trust on PrepLadder, then just go ahead and revise your MCQs and the notes of whichever company you have. So that's good enough revision. I mean, you don't have only Gynae to read, right? You have another 18 subjects. So if you have the notes and you've done all the questions for the last 3 years, enough preparation, move on. Pick up biochemistry, pick up, guys, biochemistry, ophthal, because I was scared of those subjects, and then forensics and micro. Please don't miss out on these 4 subjects. That's because some of these subjects will give you very good marks. I mean, if you read biochemistry well, 15 out of 15. If you not read it well, you will not get 15. You may get 0. So biochemistry, ophthal, extremely scoring. Medicine, surgery, gynae, if you do well, out of 40, you will get 30, 32. If you don't do too well, you may still get 25, 26 because you've read that as a subject, major subject in your MBBS. I mean, that's the way I think. I've always been telling you that. Okay, let's move on. Packing, congestion, ring pessary, discontinue. Levo dose again and again. Somebody's asked me, 2-3 people have asked me. I think I've told you now, so it's fine. Metrazole, trichomoniasis, levo-dose. Anthropoid. Direct occipital-posterior, and if it stays like that, it is known as persistent occipital-posterior, and persistent occipital-posterior delivers with face to the pubis. So please remember, face to the pubis is not in face to the pubis delivery is not in face delivery. All right, it's not in face presenting part. It's in occipital-posterior. Okay, mistakes are done sometimes. AP diameter more than transfer diameter. Threefold में खड़ा होता है, right? Great, guys. So I think the chat stopped now, and I don't have any more new questions. So I hope all of you do extremely well. Please have the time to revise. Revision is little tough, boring kind of exercise. All of you know that. But if you don't revise some things which you have read and you've tried to inculcate for the first time, if you don't revise, you tend to forget them. Things which you've been working on, clinical things which you are always up to date, and you are seeing clinical things in your internship and your clinical life as final year students, you will remember them. But the small intricate details which you've read recently while your preparation for the last 6 months, they will be missed if you don't revise. So it's a boring exercise, I know, but please revise. And for the sense of completion of course, 19 subjects, you can never say that I've completed my reading. But for the sense of completion of notes, if you've been reading for the last 6 months, please revise your notes and the MCQs like I told you. So you know you finish surgery, you finish path, you finish micro, you finish ophthal. You'll get a sense of completion and confidence. When you have confidence of finishing your course, you do better than the person who is extremely nervous on the day of exam because I could not finish my course, because you have just too many books to read 1 week before the exam. So just to give yourself confidence when you approach an exam, please read wisely, read from your notes, and revise from the MCQs which we've given free of charge. 19 subjects from PrepLadder are there on the YouTube. Please revise with us, and whichever source you have, it's all right. I mean, however you've been reading, you're most welcome to make your choice. But then if you're listening to this lecture for this long, I hope you will follow this bit of advice from my side also. And thanks for staying back. Rather long session. I did not realize that I've exceeded much more than the time I was told to take this session. But if you stayed back so long, I hope you benefited from this session. Do well. God bless you. And get back to me sometime and tell me that each one of you got what you wanted in your life. All right. All the best. Bye-bye.